Thank you, Lee. I'm not sure about that first statement. I'm not sure as Dr. Cage here is probably, I think, the best surfer here. We all know that. But thank you again, Kyle, Lionel, and Lee, for my most coveted invitation for speaking every year. Thanks for inviting me back. These are my disclosures. I always like to start with an annual, just brief blurb about surf history. And I wanted to talk this year just very, very briefly about Duke Kahanamoku, who you might have seen multiple statues and pictures around the hotel. He's even been on a USA stamp in the past. But it's too much to fit on one slide, but I wanted to talk just a little bit about some of the things that he's been credited. He's widely credited as being the single person who popularized surfing outside of Hawaii. He was known as the father of modern surfing, the king of Waikiki Beach, five-time Olympic gold medalist, including 3 gold medals. He introduced surfing both to Australia and the United States. The only person ever inducted into the Swimming Hall of Fame, Surfing Hall of Fame, and the U.S. Olympic Hall of Fame. He's a sheriff of Honolulu for 13 consecutive terms. Has been in 28 Hollywood movies and was credited with the most superhuman surfboard rescue act the world has ever seen, and is the reason why lifeguards all use surfboards to rescue people in the ocean now. So really a larger than life figure. And also, this is a wonderful connection between Northern California and Hawaii. This is another one. He visited us in NorCal in Santa Cruz and did some surfing out there. This is a picture, and I always like to just highlight how central this location is to surfing culture, because you can see the Duke front and center here in front of the iconic banyan tree. So in the past, I've talked about anterior and lateral approaches, one of my real passions, and this is, I just want to breeze through this because I've talked about it before, but benefits improving lordosis, disc height, and foraminal height with an ALIF. And we did some studies on this, looking at BMI and how this affects complications and how it can influence MIS approaches. What we found was with a BMI of greater than 31, we saw a significant increase in complication rates. And so what I took away from this is that these patients do have increased risk of complications. They're mostly post-operative. They should be counseled, and we should pay attention to wound healing, particularly when closing and following these patients, but also consider lateral positioning. And this is where minimally invasive surgery really becomes important for anterior surgery. Advantages of working in a lateral position: improved surface area for fusion, release of the contralateral annulus and osteophyte, as well as indirect decompression. Always critical when thinking about anterior approaches to take a different form of history than we typically take in spine surgery, especially thinking about any prior treatments to the patient's abdomen or vascular disease, which can be really critical. Now, some of my videos haven't been working, which may be okay for the sake of time. But this is one of my past fellows made a short video about combined single position anterior and lateral approaches from L1 to S1 using a lateral ALIF at L5, S1, and direct lateral approaches transos from L1 to L5. And you can see the benefits for the obese patient where gravity pulls the abdominal contents away. This is how I plan the incision for the lateral 5-1 ALIF. And it's a muscle splitting approach, so potentially lower risk for hernia, less retraction, lower risk of ileus. And in this position, you can use all of our standard approaches once we actually get to the spine. It's a direct lateral approach using large osteotomes, ultimately removing the disc, a Cobb instrument to remove the end plates, as well as curettes, and ultimately being able to place a lordotic, large footprint graft through a less invasive approach. Now, this can be applied also to a true pure minimally invasive operation. For example, in this patient, a 76-year-old male, He has left-sided low back pain as well as significant radicular symptoms. He's had a laminectomy in the past. And sequential MRIs can show that he's had a laminectomy again at 3-4, but has lateral recess stenosis, and looking through the frame, and he has multi-level foramental stenosis due to lumbar degenerative disc disease and spondylosis. He has a 31-degree PILL mismatch and a little bit of degenerative scoliosis. Often in these cases, I'll think about the MISDEF algorithm that Praveen published, which can help select which patients are appropriate for MIS approaches and which aren't. This patient falls somewhere between a class 2 and class 3. Sometimes I'll push that envelope a little bit as techniques evolve, but I felt that he would be a good candidate for a pure minimally invasive operation. And this will just a little intraoperative video, initially starting with the L5S1 lateral ALIF, and then single position direct lateral L3-4 and L4-5 to place interbody grafts and release the osteophytes, as you can see there. And then as a planned second day, second stage, did multi-level tubular decompressions and perk screws. And overall, I was happy with the result. Here you can see after day 1, interbody grafting, and day 2 with the final construct, and this is in the AP plane. And he did well. Now, when thinking about different types of MIS approaches when treating degenerative conditions of the lumbar spine, I will often think about the minimally invasive interbody fusion algorithm that also Praveen published recently. When thinking about goals of surgery and the level of surgery, it helps select what type of operation, whether it's direct lateral, adding anterior column resection, doing a TLIF, or an ALIF. And also I'll think also about if there's any coronal deformity, and in these cases I think are very, very good situations for using a direct lateral or lateral ALIF at L5S1. Now, having covered the anterior and lateral approaches, I also want to move on to talk about the minimally invasive TLIF. And this is my workhorse when it comes to treating lumbar degenerative disc disease. And I don't know if I've ever told you this, Dr. Fessler, but my real passion for minimally invasive surgery started, I think, in about 2009, 2010, when I was a resident at UCSF, and you gave a wonderful grand rounds that ultimately stated that minimally invasive surgery really should be the standard of care for treating lumbar disease. And that really stuck with me, ultimately really got me excited about minimally invasive surgery. I wrote this paper when I was a fellow on, it's a meta-analysis comparing multiple trials available at the time of minimally invasive TLIF to open TLIF, almost 1,000 patients in each group. And some of the things that we showed was an equivalent fusion rate between minimally invasive and open TLIF. There are lower complications in the minimally invasive group. And while there's equivalent early pain in both groups, when looking at late pain, minimally invasive TLIF had significantly lower pain scores compared to open TLIF. I wanted to extend this a little bit further, and so I started using Chris Ames' Adult Spinal Deformity Frailty Index and applying that to some of my minimally invasive TLIF patients. And I was interested in comparing how frail patients and non-frail patients did when undergoing either a minimally invasive or an open TLIF. And I was pretty interested in these findings. When looking at hospital discharge, what you can see here is that in frail and non-frail patients treated with open TLIF, the frail patients at a significantly higher rate were going to locations other than home. Whereas doing a minimally invasive TLIF in a non-frail patient or frail patient kind of leveled the playing field. And so both of those patients were doing about equal when it came to discharge location. And we found that also with respect, that same trend also persisted when looking at revision surgery out to 2 years. And so minimally invasive surgery in frail or non-frail patients really did about the same in their requirement for revision surgery over 2-year follow-up. One of the reasons here, this is one of my favorite papers that Dr. Fessler put out, which was looking at open and minimally invasive lumbar decompression patients and looking at the cross-sectional area of their paraspinal muscles. And interestingly, or kind of as expected, the open group, they had decreased cross-sectional area post-operatively after an open operation, whereas the minimally invasive patients, not only did their paraspinal muscles not decrease in size, but they actually improved over about a 6-month follow-up, and it really highlights minimally invasive approaches do preserve those paraspinal muscles that are so critical. One of which is the multifidus muscle. This controls intersegmental motion of the spine, and any atrophy or injury to this muscle can really affect spinal function. Minimally invasive surgery can decrease the injury to this. And these coronal images show the really complex insertion and attachments of these muscles, which highlights how important they are. So moving on to a couple of cases to illustrate some of these points, I want to include a few non-fusion patients just to show that not all degenerative disc disease requires a fusion. I'm going to move through these fairly quickly, but this case one is a patient, 33-year-old environmental scientist, has some back pains recently and left leg pain, developed a foot drop. And although she does have multi-level degenerative disc disease, perhaps a little bit advanced for her age, she has a very large lumbar herniated disc at L4-5, which is the explanation for a neurologic deficit. This video is not going to allow me to advance fast enough to get through it, but she was treated with minimally invasive microdiscectomy through a 16-millimeter tube, discharged same day. This is her radiographic outcome, and her foot drop resolved. Slightly different case, this is a 55-year-old male who has neurogenic claudication, is very, very severe stenosis at L3-4, has tried everything. He also has multi-level degenerative disc disease, but his real problem is neurogenic claudication. And I felt that this was a good candidate for the minimally invasive unilateral laminotomy with bilateral decompression, where from a one-sided approach, you can angle the tubular retractor in the microscope and actually decompress the contralateral side from that approach. We'll skip this video. But this is a different case, but a patient that I got a post-operative MRI on, and you can see that you can get a nice bilateral lateral recess decompression. Last case, this is a 72-year-old female with low back pain. She has left, right, and right leg pains, tried everything, and has L4-5 spondylolisthesis, shown here on x-rays. And this is a patient that I felt needed a fusion. It's unstable between flexion and extension. And some of the rationale for using a paramedian minimally invasive approach for lumbar fusions is that a lot of the blood supply and the nerve supply to the paraspinal musculature is coming off of the mammillary process, which is our typical point that we expose through open approaches. But minimally invasive strategies to perk these screws can theoretically preserve these important muscles. The technique I use is one we wrote a short paper about, using hybrid of navigation, which Sig described as one of the innovations that we use in spine surgery, combined with some spot fluoroscopy. I use O-arm, and really many of these steps I'm using navigation for, so pedicle screw placement, obviously K-wire placement on the side of the T-lift. Again, for the residents, we're using navigation to plan the tube placement. I use a 22-millimeter tube. I plan my facet resection with navigation, both inferior and superior articular process, and define the disc space to get my trajectory for cage placement. And then a few fluoroscopic images just to make sure that the end plates aren't being violated when placing that cage. And then subfascial rod placement. I'm going to skip this video, but again, showing the 22-millimeter tube. And this is intraoperative fluoroscopic images showing disc space distraction and placement of an expandable interbody cage. It's beyond the scope of this talk, but recently I've been using robotics for these cases, and happy to discuss that offline if anybody's interested. Now, because of those frailty results, I was interested in being able to expand some of the indications for minimally invasive TLIF, and one of those ways was with adjacent level disease. And this was published recently in Operative Neurosurgery. Adjacent level disease happens about 2% per year after fusions, and in general is an indication for an open extension of decompression and fusion. But my hope was to to write about a technique that I've been using to minimally invasive remove and exchange the hardware, and then do a minimally invasive TLIF at the adjacent segment that's become diseased. I'm going to skip this video, but 14 patients were included. There are different combinations of levels, a number of levels that were re-instrumented and a number of levels that were ultimately fused with about a 9-month follow-up. There was one hematoma, otherwise no reoperations. This is a busy slide, but there was actually good maintenance of spinopelvic parameters after this operation. Next, I was interested in the ability to do decompressions adjacent to fusions. And I was thinking about this because Roger Hartle and his group described the 1.5 or 1.5 minimally invasive TLIF, where he's doing a hybrid construct, fusing the unstable level minimally invasively and then doing adjacent level decompressions. He published a technical paper on this and followed this up with a biomechanical study showing that it's safe as long as you preserve the facets. And I felt that I had been doing this in my practice and no one had demonstrated any clinical results, so this was just recently submitted for ESMIS for this year, comparing what we call the 1.5 plus minimally invasive TLIF, because often I'm adding additional levels of decompression in addition to the TLIF, or doing multi-level TLIFs with adjacent level decompression. Total of 72 of my patients were included. They're fairly well matched. I was comparing the number of levels that were treated to the equivalent number of levels treated with an all-fusion construct. So in other words, a patient that had an adjacent level decompressed above a TLIF would be compared to a 2-level minimally invasive TLIF, and collected radiographic outcomes as well as clinical outcomes. The 2 pieces of data I wanted to share was there was actually a slight improvement in lordosis in the 1.5 group, so the group that didn't get the whole thing fused compared to minimally invasive TLIF. A slight trend towards reoperation of the adjacent segment, although this didn't reach statistical significance. And otherwise, comparing adjacent segment disease or pseudoarthrosis, there were no differences comparing the 2 groups. And lastly, I've become interested in the ability to add more lordosis to the minimally invasive TLIF. Again, going back to one of Sig's points today about limited ability for lordosis with minimally invasive approaches. And what we've been doing is particularly focusing on 5.1, where it's so critical, is using bilateral complete facetectomies done through 22 millimeter tube, bilateral interbody cage placement, typically with either custom cages or expandable cages. For this study, still kind of in the early stages, but there are 13 patients, 7 patients just 5.1, and 6 other patients that had 4:1, and had fairly long-term follow-up, about a year on average. Here are some representative slides of preoperative imaging. This is a patient that had a bilateral 5.1 minimally invasive TLIF, and this is a patient that had 4:1 done minimally invasively. Both had improvement slightly in some sagittal parameters. When looking at all these patients together, there are some slight trends towards at least not worsening of 4:1 lordosis, maybe slight improvements in 4:1 and 5:1 lordosis, and similar slight trends in PILL mismatch. So in conclusion, lumbar spondylosis is very common. It can be debilitating and costly. Surgery is indicated for those who fail conservative management. Minimally invasive techniques offer many advantages over open surgery. And there really are MIS options for virtually all of the conditions that are associated with degenerative lumbar spondylosis. Thank you guys again.